I am here at ARVO with Dr. Sadda. Dr. Sadda, you just presented on SHRM here at ARVO. Can you briefly explain what SHRM is and why it matters clinically? What is its relevance?
Sure, yeah, thank you very much. So I had an opportunity to present about SHRM here at ARVO, and SHRM stands for Subretinal HyperReflective Material. It's basically material in the setting of neovascular or wet AMD that accumulates between the RP and the photoreceptors. And in particular, the SHRM that we're talking about is really the neovascular tissue and its associated exudative components, things like hemorrhage or thick a fibrinous subretinal fluid, which again can be hyperreflective. Those can appear as SHRM, which again, the subretinal hyperreflective material we're talking about has this sort of heterogeneous reflectivity and not to be confused with subretinal drusenoid deposits or acquired vitelliform lesions.
Or fibrosis.
Well, fibrosis is actually a later stage of SHRM. So early on in the exudative process, there's not much in the way of fibrosis, but if you allow SHRM to persist over time, then it can become more compact and hyperreflective, and then we call that fibrosis. The reason it's important is because it is between the RP and photoreceptors, so not surprisingly, it's deleterious for visual acuity.
So how the presence of SHRM influence your care or your strategy with AMD?
So because we and others have shown that SHRM is associated with worse visual outcomes, it's very critical that we try to eliminate it as fast as possible. So because we're in an era where we have multiple therapeutic agents, we're now very interested to see other agents that can better eliminate the SHRM, given that we know that it's so tied to vision.
So concretely, we should treat earlier with SHRM and faster, that's the point.
So we need to treat earlier and more aggressively with SHRM, and I will also emphasize to treating physicians to treat more completely. So the point is you want to get rid of SHRM early on, and you want to get rid of it as completely as possible, because that's probably going to be the best way to maximize vision outcomes for patients.
So we should look for it on each OCT?
You need to look for it in every patient we're treating with wet AMD. In the presentation I gave today, one of the things I highlighted is that you see greater and more rapid resolution of SHRM with faricimab compared to aflibercept 2 milligram, and that's something that persists through the course of the study. And we also verified or validated our previous findings that it is correlated with vision, meaning that patients who you allow the SHRM to stay or have persistent SHRM at 12 weeks, those are the patients who end up with worse vision. So it verified the previous findings, but also showed that, yes, there's a difference amongst agents in terms of the resolution of SHRM.
Thank you very much.